You've seen the headlines. Semaglutide, Tirzepatide. These GLP-1 medications are changing the game for weight loss and diabetes. But the question isn't just, do they work? It's, are they right for me? The answer is critical, and it lives in the medical fine print, the contraindications and warnings. Today, we're translating the label language and professional guidance into plain English. We're drawing the line between the hard NOs, the absolute contraindications, and the slow downs, the serious cautions that require a plan. Let's figure out if GLP-1 is a green light, a yellow light, or a red light for you. Let's start with the hard stops. Across all the modern GLP-1 and dual agents, there are two clear, regulatory red light contraindications. Number 1. A personal or family history of medullary thyroid carcinoma, or MTC, or multiple endocrine neoplasia syndrome type 2, MEN2. Rodent studies showed C-cell thyroid tumors, and while the human relevance is debated, regulators take this seriously. If you have this history, the answer is a firm no. Number 2. A known, serious hypersensitivity or allergic reaction to the drug or any of its ingredients. If you've reacted badly before, you can't start again. These are the two non-negotiable hard stops. Everything else falls into a category of strong caution, situations where the risk may outweigh the benefit, or where careful planning is mandatory. These can still be decisive. These medicines slow down stomach emptying, that's how they work. But if you already have severe gastroparesis, markedly delayed emptying, GLP-1s are not recommended. In this setting, the slowed motility can lead to persistent vomiting, dehydration, and malnutrition. Even without gastroparesis, severe GI symptoms like prolonged vomiting or diarrhea can cause dehydration. If you have chronic kidney disease or are vulnerable to volume depletion, make sure you have a plan with your doctor for gradual titration and lab checks. If you are pregnant or planning a pregnancy soon, you should stop the medication. For semaglutide specifically, the label advises discontinuing at least 2 months before a planned conception due to its long half-life. And a practical detail for oral contraceptive users, particularly with tirzepatide, because it slows your stomach, it can reduce the absorption of your birth control pill. The guidance is to use a non-oral or barrier method for 4 weeks after starting and after every dose increase. Don't overlook that planning detail. GLP-1s carry warnings about acute pancreatitis and gallbladder disease, including cholecystitis. While causality is complicated, rapid weight loss itself can cause gallstones. Cases have been reported in clinical trials. If you have a significant history here, your prescriber needs to weigh the risks. If you develop new, severe upper abdominal pain, that's a signal to stop immediately and get evaluated. For people with diabetes, if your blood sugar drops too fast, it can temporarily worsen pre-existing diabetic retinopathy. If you already have moderate to severe eye disease, monitoring is key. This isn't an automatic ban, but you should loop in your retina specialist before starting a potent therapy that promises rapid A1C reduction. Warnings exist on weight management labels regarding suicidal behavior and ideation. If you have current major depression or a recent history of suicidal thoughts, this is a reason to pause therapy or coordinate care closely with a mental health professional. If new or worsening ideation occurs after starting, discontinuation is advised. Because these agents slow stomach emptying, they increase the risk of pulmonary aspiration. That's when stomach contents enter the lungs, during general anesthesia or deep sedation. It is essential to tell your surgical or procedural team you are taking a GLP-1. Protocols vary. They may ask you to hold a dose, but disclosure is mandatory for safe procedure planning. 2 practical interactions stand out. First, when combined with insulin or a sulfonylurea, the risk of low blood sugar or hypoglycemia increases. A proactive dose reduction of those older medications is often needed. Second, never combine a GLP-1 with a DPP-4 inhibitor. The current standards of care advise against it. You get the added cost and pill burden without any additional glucose-lowering benefit. If you switch, you stop the DPP-4. So where does that leave us? If you have MTC/MEN2 or a severe allergy, red light. If you are pregnant, planning to conceive in the next 2 months, or have severe gastroparesis, not now or not without a plan. If you have a history of pancreatitis, advanced diabetic retinopathy, or take medications with narrow therapeutic windows, proceed with caution and planning. For everyone else, especially those with type 2 diabetes, obesity, or cardiovascular disease, the calculus is usually favorable, provided you match the drug to the indication and titrate slowly with attention to side effects. Don't let a warning become a reason to self-reject a therapy that could be life-changing. Instead, use these points as a checklist to have a detailed, informed conversation with your clinician. Thoughtful pre-work turns many of those flashing yellow lights back to green. These are the sources we used in case you would be interested in learning more. Hit the like button if this video helped clarify the confusion, and subscribe for more evidence-based health deep dives. We've linked all the FDA prescribing information and ADA standards of care we referenced below. Thanks for watching.